Morning, Chris Ohl, Wake Forest, School of Medicine, Infectious Diseases. COVID update for the second week of October 2021. So across the country, cases continue to come down, coming down in the fastest in those areas that were the highest back in August, which is the South and parts of the Midwest and some of the Southeast. And, the upper Midwest and the Northwest, cases are actually going up in those areas. Some speculation, it might be because with the colder weather arrival, more people are spending time inside rather than outside. And so more cases, more chances for transmission up there. Vaccination rates in a lot of those areas never were all that high. If you want an interesting graphic to look at Minnesota and Wisconsin and the disparity between the counties, and then take the vaccination rate map and lay it over, and it's almost perfect, and how they come over each other. So in Wisconsin, as soon as hunting season happens and everyone goes outside, and I mean everyone, puts on their orange and goes outside, maybe their rates will come down then. It's a joke. So here in our area, in the Triad, cases are coming down slowly in Forsyth and Guilford County. Look, this morning we're at 31 per 100,000 per day on a 7-day average. And that's coming down about ticking down about 1 or 2 per week. Haven't really seen any super spreader events or real problems from the fair. Might be a little bit hard to sort out with contact tracing, but I think we had a great time at the fair. Attendance was down a little bit this year. I think a lot of it attributable to the weather, but a nice outside event for people to get out and eat unhealthy food and have fun. So as far as our hospitals, our numbers are coming down of hospitalized patients. Still, of all patients, about 95% of them are unvaccinated. In the ICUs, even higher are the unvaccinated group. Our ICU numbers are coming down a little bit more slowly, and that is largely because if you're hospitalized in an intensive care unit with COVID, your length of stay can be up to a month or even longer. So the ICU, it'll take a little bit longer for the prevalence numbers to come down there. We're still seeing cases in our kids. The numbers of them who are hospitalized is less than it was a month ago. But we are seeing more of the multi-system inflammatory syndrome for children, MISC now, which kind of makes sense because happens about 4 to 6 weeks after COVID itself. And so the peak was about 4 to 6 weeks ago. And so we're seeing MISC. The numbers are still extremely small, and it's still an extremely rare event. And it was kind of predicted that we might see that. We're still seeing some cases and some clusters in our schools or associated with schools. Here in this area, the mask mandates are largely in place still for all of our schools, and that is really helping out a lot because the schools are largely doing pretty well. There's some people quarantining because of exposures and a few cases that are transmission generally outside of the school environment. It's kind of interesting talking to some of the schools. It's little family clusters. So if you think about it, most families will have, a 7-year-old, a 9-year-old, and a 12-year-old, or, there'll be 3 kids, and then there'll be an exposure in the household, and then all the 3 kids get it, particularly those under 12 who haven't been able to be vaccinated. And so they all quarantine out, so it makes the numbers a little bit higher, but they're kind of focal little areas. Universities are doing pretty well, including Wake Forest University here in Winston. A few cases associated with their fall break, which occurs last week. Some people who were traveling, and came back, but largely the numbers are very small compared to what they were last year. So how about therapy, treatment for COVID? We don't usually talk much about that because there aren't a lot of, haven't been a lot of options out there. Monoclonal antibodies are still on the docket, particularly for people who get COVID and it's early in their course and they have underlying health conditions or in older ages. And they seem to benefit the most, particularly the unvaccinated group. It's not a magic bullet though. I mean, we still have people who got monoclonal antibodies who get hospitalized, and even a few will land in the ICU. And it turns out that getting vaccinated is a much better option for keeping you out of the hospital or out of the ICU than monoclonal antibodies. But there is some efficacy there, and it does work. Unfortunately, they're in short supply. They're hard to make. Distribution is difficult. They have to be infused in a special infusion center. Not a lot of those around. We have 3 centers, I think, here with our health system, Wake Forest Baptist Health, one up in Wilkes, the FEMA site, one here in Winston, and one in Guilford County. So you can check our website if you think one of you or your loved one might benefit. I think largely healthy people who get COVID, who've been vaccinated in particular, really don't need monoclonal antibodies. I'd probably let the people who are more vulnerable get that rare drug. Monoclonal antibodies, though, in about 6 months will be a done deal. I don't think we'll be doing them anymore, and except for particular immunocompromised hosts who have problems making antibodies because of advances in antiviral drugs against COVID. The big one and the big news this week, molnupiravir, following their announcement 2 weeks ago that their phase 3 study actually was halted early because the drug worked so well that they had their endpoints met, and their safety group says this drug works so well we need to get it out in people, so let's go ahead and stop the trial and get people on it. And Merck, who makes the drug, submitted it to the FDA this week for an emergency use authorization. Safety data looks good with it. We don't have a lot of specific information about it yet. That'll be coming out, I think, as the FDA goes through it. But it, in the press releases, reduces hospitalizations and deaths by about 50%. It's a 5-day course. It's 4 capsules twice a day. And so the goals for using this, particularly initially, will be treating people who are over the age of 60 or so and people who have underlying health conditions. It was studied particularly in people who have diabetes, who are overweight and have obesity, who have heart and lung disease. So those would be the people, I think, that the FDA will say that this drug makes the most sense in. And so it would be given to people early in their treatment course, within 5 days of the onset of symptoms. So it's kind of like a Tamiflu that we use for the flu, but this one would be used for COVID. So once that comes out, I don't think monoclonal antibodies will be needed anymore. Why go find an infusion center and sit for 3 hours for a $5,000 drug when you can get a $700 treatment course with a prescription from a pharmacy? There'll be more antiviral drugs coming out in the future, and this is going to change the way that we approach COVID. It'll mean that people will need to get diagnosed quickly so that the drug will work. Like all antiviral drugs, the quicker you get it in, the better it works. And it'll also mean that people will need to get tested to have it sorted out. So if you're a person who's a bit overweight and you're 68 years old and you have diabetes and you get a cough, a fever, and some chills, You need to find out, is it the flu, is it COVID, or is it some other of those sorted viruses? So you'll need to get tested. If the test is positive for the flu, you'll get Tamiflu or the other drug, Relenza. If it comes back positive for COVID, you'll get the Molnupiravir drug. And it'll be helpful in that situation. We'll have to see as time goes on. There are some potential other uses for these antiviral drugs that can be gotten by prescription. One would be to prevent influenza. So Johnny brings home COVID from his football team party and exposes Grammy in the house. Grammy is older and has some underlying health conditions. And even though vaccinated, still remains a little bit higher risk. And so that would be, you would prescribe it for Grammy to keep her from getting it from Johnny. That's called prophylaxis. And we do that with Tamiflu for the flu actually now. So a little bit about the antiviral drugs. Will they become something that everybody needs who gets a COVID cold? So a vaccinated person without other health problems really? Probably not. I don't think. It hasn't been studied in that group yet. Probably won't get the FDA EUA for that group. Probably won't make nearly as much difference because those people largely have self-limited cold-like illnesses. Boy, it's a busy month for the FDA. They're looking at boosters, and this includes Moderna's drug, which is being talked about today in the advisory committee. They've been talking about Johnson & Johnson's drug, the one-shot drug, and then they're going to be looking at mixing and matching. So if you've got Johnson & Johnson, is it best if you get a Moderna or a Pfizer or another Johnson & Johnson? Or if you got Pfizer, should you get a Moderna as a booster? If you got Moderna, should you get Pfizer as a booster? So there's a lot of permutations. That's all being talked about. I think it's probably going to get sorted out sometime around the end of October, maybe the first week in November. And you'll see public health guidance coming out of the CDC and the NIH and the Infectious Diseases Society of America about how to boost. If you need to boost, how would be the best way to do it? I can give you a little bit of insight. I think for those people who got Johnson & Johnson vaccine, it seems like the data shows that the best boost for you is going to be with the messenger RNA vaccine. So what you would do is get a second dose of vaccine, but it'll be one of the messenger RNAs, either Moderna or Pfizer's vaccine. Probably won't matter too much which one of the two, but it seems to give you a better immunologic boost as reflected by antibody testing than just getting a second shot of the Johnson & Johnson vaccine. So that's good news because I know a lot of the Johnson & Johnson people have been kind of feeling left out in the booster world. And so within a few weeks, we'll have an answer. The other thing is what about the EUA for kids? This would be a reduced antigen vaccine for our 5 to 12-year-olds. I am guessing that this will be heard by the ACIP. In fact, this meeting's already been scheduled in the first week in November. So it'll get the FDA EUA before Halloween. It'll get heard by the ACIP. The ACIP then says, hey, this is the best way to do it. This is who should get it, which will be largely anyone who's between the ages of 5 and 12. It looks safe, and there have been no signals of unusual, untoward events with the vaccine. They do seem to get some soreness at the vaccine site, and roughly about 10 to 15% might get a fever, which is less than adults who get the booster. Most adults who get the booster will have the same side effects they had with the second dose of the messenger RNA before. So once we start getting kids going, we have to get the vaccine distributed because it's a different vaccine than the adult vaccine. And once it's distributed, we'll start immunizing. I had a good conversation with Joshua Swift, the Forsyth County Health Department next week, and we'd like to have some school events for vaccination in our public and private schools in the county. And it'll be a little bit more complicated than the school events that we had before because we'll need the parents to be there for a couple reasons. One is for parental consent, which now North Carolina law changed and is required. And then the other is because kids between the age of 5 and 12 like their parents to hold their hand when they get a shot. And I certainly plan to be there for my children's shot. It's so we can start thinking about scheduling those now a little bit together with the health department. I think that I really encourage parents to get their kids, the 5 to 12-year-olds, and even the 12 to 16-year-olds who are eligible now, vaccinated. I know that a lot of the parental hesitancy has to do with myocarditis, which is an extremely rare event, roughly about 50 people per 1 million who get the vaccine. I'm thinking that with a reduced antigen vaccine, that'll be actually of a lower risk problem than we had for the older kids. Again, 50 to 60 per million people is an extremely low number. And it turns out that the risk of getting myocarditis from getting COVID itself is much higher. So let's get our kids vaccinated. It'll be a great way to go into our Christmas holiday season because with all of our kids vaccinated, family events are going to be a lot easier. There won't be as much horizontal transmission from social events and such with our kids. And we'll be able to start thinking about it, having sleepovers and indoor play events. It'll be a great thing for our kids. So let's get them vaccinated when it's ready. So let's talk a little bit about boosters because I asked for questions for today. Thought most of them would be about Halloween. I was wrong. Most of them are about boosters. So I was asking myself, there's been so much confusion about boosters all along, both from the media and from people. And I was trying to think why, to me, it's not so confusing, but I'm an infectious disease doctor who specializes in emerging infections and have a lot of background in vaccines. So I was trying to think, why are people so confused? And here's why it is because usually when we come out with a new vaccine, let's just pick Shingrix, the shingles vaccine. When it comes out, we say, here's the Shingrix vaccine. And here's what it can do for you, and here's how you can get it, and here's the vaccine schedule. You get one now, you get one in 6 months. And that's how we're going to do it. Same thing with human papillomavirus, HPV vaccine when it comes out. Here's the schedule. A new meningitis vaccine, here's the schedule. So when we brought out the COVID vaccines, we did it under an EUA. We needed to come out quickly to save lives. So the schedule thing was still being worked out because it takes time to go through that and to get those studies done. And so now we're starting to get the data from those studies. And we're learning a few things. One is that extending the interval between the first and second dose probably works better. Two is that it's probably going to be a 3-dose schedule for the messenger RNA vaccines rather than a 2-dose. And so we have to do a little bit of catch-up, a little bit of adjusting as we get that additional information. And is that a problem? Did people mess up? No, it just means we wanted to get the vaccine out when we knew it was safe and we knew it was highly effective. We wanted to get it out to save lives and keep people from getting COVID while we were still collecting the data on the best way to do the schedule. And And that's what's happening now. But it's confusing people because we have 3 different vaccines with 3 different groups of data. I think it's going to end up being that the messenger RNA vaccines will end up being on the same schedule. I'm guessing it'll be 3 shots. And then will we need boosters afterwards? I don't know. We'll have to see. Maybe not. I think the 3-shot will provide enough robust immunity to keep people from getting serious diseases from COVID, getting hospitalized and getting infected. Would it prevent all breakthrough infections? No, that's a tough call for any vaccine to do, particularly considering the respiratory infection infects the nose and the back of the nose area and the throat, and that's a harder place for a systemic vaccine to reach. But it means that it will limit it to that area. So it's kind of like people who are getting, you get a cold due to the virus rhinovirus. You've probably had rhinovirus 5 or 6 times before in your life. You're largely immune from serious infections from rhinovirus, but it keeps it to the nose. And that's what's going to happen with COVID. So, which brings me to it's more than speculation. Predictions, and I'm pretty confident about them, is how the COVID will end. It's not going to end with a bang. It's going to slide into being an infection that still occurs, but largely is not a problem. It doesn't land people in the hospital. It doesn't result in death, except for highly vulnerable individuals. So what does that mean for the holidays and January and February, our usual viral respiratory season? It means that COVID will still be around, but I think flu will also be around this year. Get your flu shot. It also, the other respiratory viruses will be coming up. We usually get RSV in March, February and March. We get parainfluenza in March and April. These are all viruses that infect our nose and cause a cough. So they'll all be around in January and February, but there'll be a lot less COVID compared to last year, which COVID dominated last year. So we'll still have respiratory viral season. COVID will be part of it, but it's not going to be quite as overwhelming as last year. But it'll mean that we will have to still get tested, particularly with the antivirals out there, if we get serious colds and flus. It'll mean that we'll have still, if you get a cold or flu, stay home from work, stay home from school, keep from spreading it. Will mask wearing still be occurred? You know, during respiratory viral season, I'll probably wear a mask still. I don't like getting colds. I can't really say how we'll be doing it for you know, citywide mandates and for schools and such. Then we'll have to see. It's going to mean that for hospitals, they'll still be busy. And it won't be all just COVID. 25% of community-acquired pneumonia, which lands people in the hospital, is a virus. Not just have to be COVID, it could be one of the other viruses. So hospitals will still be busy, we'll have to plan for that. Doctors' offices are always busy during respiratory virus seasons, particularly pediatricians' offices. They will be this year too. So it's just something to think about. I think once April comes along, COVID will have slid enough into the background in most places, particularly for vaccinated people, that they will be able to relax a lot of the things that we're having to do now. And at some point, even within a year, I think that quarantine and isolation for COVID might be a thing of the past. We'll have to see. But it all depends on how many people we can get vaccinated, how many people become immune, and how well we can protect our vulnerable populations. as COVID slides into the background. All right, we asked for questions last week. Let's go through a few of them. First one has to do with Halloween. I love a good Halloween, by the way. Let's have a good Halloween this year. I think trick-or-treating's fine. Trick-or-treating, obviously, is largely an outdoor event. I think we've learned enough about viruses hanging out on surfaces and things like candy and such. If you are worried about that, you can just let your candy sit for 24 hours, which is probably not a bad deal anyway for the parents, so the kids don't get that post-Halloween tummy ache, and then the next day there's not going to be any virus on it. It's outdoors, and that we learned is a good thing. If you're going to be in a large group that's kind of hanging out all together, and how kids like to hang on each other, you can wear a mask underneath your mask, and that'll provide more protection. So let's have Halloween. One thing about Halloween that comes up are indoor parties. I still think that indoor parties this year for Halloween, our case rates are still going to be high enough, and there'll be enough transmission in our community that indoor parties for this year's Halloween are not a good idea. And that includes for adults. Now you could say that, we'll require all of the adults coming to the party to be vaccinated. That'll help. That'll provide some protection, but there's still a possibility of breakthrough infections in that situation. Remember the CDC study that showed us about how breakthrough infections can occur and can transmit among vaccinated people were people going to parties in Provincetown, Massachusetts. And so I think indoor parties for Halloween, not such a good idea. Outdoor parties, get the patio heater out, fire pit, things like that, those are fine. And go for it. But I'd stay away from indoor parties, both for kids as well as adults. And Lauren asks, any ideas for a couple who's quarantining during Halloween? Well, I guess if you've been exposed and you're quarantining and it's Halloween, probably better to put a scary movie on and eat your popcorn balls yourself in front of the TV. You don't want to be around other people. You could get a surrogate or somebody who's not in quarantine to come out inside your house, put up a table, and hand out things like that. You can still put out the decorations in your front yard with all the scary sounds and stuff, and participate that way. But if you've been exposed and you're quarantining, you don't want to participate in the Halloween activities. Now, if the question pertains to, like, if you're quarantining because you're going to be traveling to visit somebody who's at high risk of getting COVID with a bad complication, and so you just don't want to expose yourself to people, it's kind of the same thing. You probably don't want to be the person at the door hanging out and giving out tons of candy. Get a surrogate or put the bowl out on the porch or something along that lines. Sandy asks, should a senior be close to unvaccinated children this year? Well, this year, as we get into the holidays, unvaccinated children will be under 5. At least it should be, because everyone over 5 will be able to get vaccinated. That group doesn't get exposed all that much unless they're in daycare and unless transmission's occurring in daycare. So it kind of depends a little bit about what your under 5 children are doing. And if they're in daycare and there's been daycare hiccups happening all along with COVID, then maybe not. Now, if the seniors are vaccinated and if the seniors are otherwise healthy and the seniors have gotten a booster, which anyone over 65 should have gotten, then I think it's probably okay. But have the kid wear a mask, have the seniors wear a mask, get a little bit more protection that way, and I think that I think it's okay. So I imagine Sandy's asking about Thanksgiving and Christmas and New Year's and Hanukkah holidays, I think there's ways to mitigate it for the kids so that they can see their grandparents. Zach asks, any reports of myocarditis associated with the booster in healthier young men? I haven't seen any yet, no, but you know, the healthy young men who are getting boosters are largely doing it outside of the areas where we would gather that information, but we haven't seen any in our health system from the booster. And there was some speculation at ID Week last week that actually the chances of getting it from a booster are going to be less than what it was from the second shot. But I imagine a few cases will occur, but they'll be exceedingly rare, and likely rarer than what they were for the second shot, which was only 50 per 1 million people. So, what is the downside to a booster shot? Brian asks. Well, I guess one downside, it depends a little bit. So it may be you're getting a shot you don't need, and there's still some debate about that for the population at large. It's very clear that people over the age of 60 to 65 or people between 50 and 65 who have underlying health problems benefit from a booster, and that is now. So if you're otherwise younger and healthier, there's still a lot of debate of how much people would really benefit. It might prevent some breakthrough infections, might prevent some colds. So that probably would be the one downside, that you may not need it. The other potential downside would be is that if when the enhanced vaccines come out, and I'm not sure when that's going to be yet, that it may mean, and so it, you know, because the vaccine's so safe, there's really not a lot of downside to it. Haley asks, when should people who are vaccinated early on with Pfizer but recently got COVID get a booster? That's a good question. So for those people who got a breakthrough infection during the last Delta wave here in September, when should you get a booster shot? Well, we don't know yet, but people who got a breakthrough infection who had been previously vaccinated do immunologically boost. So it's kind of like you got your booster when you got that breakthrough infection. And it'll take a little while for us to sort out whether a vaccine will further provide more protection on top of that. But I think you got more time. And I think I would let the whole booster thing sort itself out and allow us to get more data about the best way to boost, when the best time to boost is. We're getting more and more information about boosters every week. And so if you got a breakthrough infection and you know it was COVID, in other words, you tested positive, you can wait. There's no problem. I got a breakthrough infection around Labor Day, and I'm going to wait for a little while for my booster, personally. So it's a bit of a personal decision. Would you get harmed if you got a booster? No, you wouldn't. Suzanne asks, please remind women about mammogram timing. Yes, that's a good thing. Thank you, Suzanne, for bringing that up. So it turns out that people who are getting boosters, so that would be a third shot, a booster shot, are still when they get their sore arm and that bit of a fever the next day, that they do get some lymph nodes that swell a bit, and that's part of the immunologic response. It's expected. It's really not a side effect. It's just part of the immunologic response to the vaccine. But those tend to occur in the armpit, in the arm that was vaccinated. Sometimes they're up a little bit on the neck, and they can be in and around, particularly the upper part of the breast tissue. And then if you get a mammogram during that time frame, the mammogram people see that and say, hey, we need to get more information about that. And they'll ask you, have you had your booster shot, or have you had a shot for COVID in the last couple months? And if you say yes, then you have to get another mammogram, which no one wants to do. So if you're going to get boosted, wait 4 to 6 weeks to get a mammogram. And then that way all those lymph nodes can go away, and you won't have to get another mammogram. So I'm glad you brought that up, Suzanne. Joy asks, any suggestions about boosters for someone who had a major eczema flare-up and tinnitus after the second Pfizer vaccine? Would Moderna be a better booster? Anything to take ahead of the booster to help with those issues? I would say probably the best thing to do would be talk to your doctor about it, or talk to your dermatologist, who's I assume would be managing eczema. This usually isn't a problem except for people who have pretty serious eczema who are on other medications and such forth. The tinnitus thing and the ringing in the ears, we're not even sure yet if that's really associated with the vaccine. As far as would it be better to get Moderna or Pfizer, in a week we'll know. That data will be out, possibly, but we'll have to see. Because there was a trial, small numbers of people, but it looked at giving different vaccines afterwards. So why don't you hang out, wait till around Halloween or the week afterwards, and then talk to your physician who manages your eczema, and see what they say. But yeah, maybe it would be better to get a different vaccine. If you don't have any underlying health problems and you're younger, then you don't absolutely have to have a booster. You're still protected enough from the first 2 shots. Patris asks, any word on when variant-targeted boosters might be available? Is it wiser to wait for those instead of getting the boosters that are same as the original shots? That's a really good question, because there will be variant-targeted boosters out. We call this an enhanced vaccine. When that'll be, I haven't seen a lot of information on that yet. I don't think it's real far off. That vaccine will include more what we call haptens, antigen for Delta, but it'll also include the ancestral strains, the alphas and everything else that we had at the beginning of the pandemic. So it'll be a broader vaccine, and so the question is should you wait for that? Well, again, it depends a little bit about how badly do you need a booster now. The data that we have, that our current 2-shot series is keeping people out of the hospital, and keeping people from dying. Now, the over 60, 65-year-old age group, I think, benefits from a booster now. So if you're in that age range, I'd probably go get the ancestral vaccine booster now rather than wait for an enhanced vaccine. If you have underlying health problems, particularly serious ones, have you been hospitalized for these before? You've seen a doctor regularly for these? You taking a lot of medicines? Then I'd go get your booster now rather than wait. If you're otherwise young and doing well and don't have a lot of high-risk conditions for COVID, it's okay to wait for it. You don't need to run out and get it now. My daughter turns 12 on December 16. Should I get her the smaller dose as soon as it's approved for 11-year-olds and wait until her birthday and get her the larger dose? She's, and they give her weight, 5'6" and weighs 110 pounds. Well, that's a good question. I hadn't thought about that one. I personally, I would personally wait for the smaller dose with that age and weight. So, well, I guess it's not really waiting because you'll be able to get that one quicker, probably, because those will be available in November. So I'd probably go ahead and get the smaller dose one in November for that age and weight. And then there'll be a second one that'll be coming up in a month or 3 to 4 weeks. It depends on what the FDA says afterwards. And I think I would follow it up with that same vaccine, the smaller dose one. Because in the clinical trials, there were people who were 11 years old and who were in that weight group, and they still did well. I think, kids at that age just respond better to vaccines than us old folks do. So, Kelly asks, there's much confusion around the J&J vaccine and its efficacy at the 6-month mark. Do you have any guidance if we wanted to switch to an mRNA vaccine? I think that's what the FDA is going to say to do in the ACIP. That's going to come out in the next 2 weeks. Let's be patient, wait for them to say that, and actually see the data itself. I'll come on Thursday morning because I'll have had a chance to look at it myself too, and back that up if I agree with that. And I think I probably will. I think that people who got the J&J vaccine will probably be better off getting a messenger RNA vaccine as a second dose. And I am guessing we're going to call it a second dose, and we're not going to call it a booster, because the J&J vaccine should have been a 2-dose series all along. Hang in there for a couple more weeks, and the answer to the question will be crystal clear. Is there a period of time, Priscilla asks, where one needs to wait after recovering from COVID to receive the flu shot? No, you can get the flu shot really anytime after recovering. Once you feel better, fever's gone away, your quarantine's over, or your isolation's over. So 10 days after from the onset of symptoms, you can get your flu shot. You don't have to wait any certain period of time. And if you're going to get a booster for COVID, you don't have to wait for that either, if you want one. Mike asks, are running events such as 5Ks and marathons safe with large crowds of runners? Outside, but hard to be socially distanced. Yeah, we have the Ardmore Run for Hunger coming up this weekend. Yeah, I think it's okay. Largely the group is at the start, at least the ones that I see. If I run, I'm usually so far away from the group in the back, it doesn't matter much, but I think it's okay to be outside in these running events. Our high school kids have been doing cross country, which is really the same thing. And they were doing it last spring, and they're doing it this fall normally. They don't mask when they run. And we haven't seen any cluster outbreaks in those kids, so I think we're okay. Is there anywhere to find out where the breakthrough cases are coming from, and are vaccinated people possibly asymptomatic transmitting COVID without knowing they have it? Boy, that's a really good question. So just to rephrase it, so regarding breakthroughs, are people who get an asymptomatic breakthrough capable of transmitting it? And I've been asking this question from the beginning because it's an important question. I think largely the asymptomatic people who are having a breakthrough do not transmit all that often. I won't say never, but I think it's a lot more unusual event. So if you look at transmission and by vaccine status, you have 4 different ways it can go, right? Unvaccinated to unvaccinated, unvaccinated to vaccinated, vaccinated to unvaccinated, or vaccinated to vaccinated. And I think if you parse all that out, and we don't have the data really 100% because most asymptomatic people with breakthroughs, we don't know much about them. They're asymptomatic, they don't come forward. I think that the highest risk of transmission is from unvaccinated to unvaccinated. Next highest is from unvaccinated to vaccinated. You go down a fair amount after that, vaccinated to unvaccinated. Yes, I've seen that happen, and that happens. Vaccinated to vaccinated, I think, is a pretty unusual event. So why can I say that? Well, one thing is our experience in the universities, because we test people who are contacts of people who've had a breakthrough. So we test them at day 5, and it's actually pretty darn unusual for a roommate to become positive who's been exposed to a breakthrough positive, and if both are vaccinated. It's a pretty unusual event. It happens, but it's pretty rare. And those are roommates in a 12 by 12 foot room. And so, and then if you look at household transmissions from vaccinated to vaccinated, it's a pretty unusual event. Usually there's one unvaccinated person who exposes the 2 vaccinated at the same time. So I think it's a lot more uncommon than we might realize. And then the other corollary to your question is there any way to find out where the breakthrough cases are coming from? It's kind of hard to do that. In household exposures, we kind of know, and on college campuses, we kind of know because we test a lot and we can sort it out. Otherwise, from a contact tracing standpoint, like at the level of a health board, it's pretty hard to know. We have some idea of what the proportion of Delta cases that occurred in the wave were breakthroughs versus not. It's probably about 1/3, somewhere in there. Different studies show different things, but so it's a little bit hard to know. Chick says, Chick is looking ahead to Thanksgiving. Yeah, me too. I love a great Thanksgiving. I don't like the diet afterwards, but I love Thanksgiving. If we have vaccinated family over and 2 more who are unvaccinated but who've had COVID, are the 2 unvaccinated people safe because of natural immunity? Largely, vaccine immunity is better than natural immunity. I'm going to say that again because this is a myth that's going around. Vaccine-induced immunity is better than natural immunity, but natural immunity is still pretty good. So I think your Thanksgiving get-together is going to be okay. Plus, I think right around Thanksgiving this year, there's not going to be a lot of COVID circulating. I think we're going to be in a sweet spot between the Delta wave that we're getting over right now and between respiratory virus season. So I think Thanksgiving's going to be a pretty easy thing this year. That's my guess anyway. But I'm going to say it one more time. Vaccine-induced immunity is better than natural immunity. Because I get these questions asked me mostly from people who don't want to get the vaccine. And if you've had COVID before and you get vaccinated, it is absolutely clear that your immunity is much better than just the natural immunity alone. And it is much more broad, much more likely to cover variants, including Delta. So if you've had COVID before, you should still get vaccinated. It's a great idea. The other, just the correlate, that's the end of the questions, but I'm getting asked a lot. I see a lot of applications for medical exemptions for the vaccine from all sorts of places, because I help other companies and schools and stuff, and universities do that. And I think one of the most common misperceptions, and one that's being pushed a lot by the anti-vaxxers, is that if you have an immunological condition, you should not get COVID vaccine. And that is absolutely 100% false. If you have an immunologic disease or condition, such as lupus or thyroiditis, or one of these things where the body attacks itself, actually you have a higher risk of an untoward or bad event from getting COVID. And it is actually a better idea for you to get vaccinated and protected from the disease. And so if you have an underlying illness that includes an immunologic component to it, you should get vaccinated. Because your risk, if you have lupus, your risk of being hospitalized or dying if you get COVID is so high compared to what it would be from a vaccine, which is basically the same as what it is for everyone else. So that's a myth I hear a lot, and just want to get it out on the table. So, any questions from the group here?
There is one that came in that said, in considering whether or not to get a booster, how valuable are tests such as TrueImmune that measure your level of immunity?
Yeah. The question is how valuable are tests to check your antibody levels to see whether or not you need a booster? Unless you're getting one of the very specific serologic tests that specifically was developed for looking at vaccine-induced antibody responses, it's not helpful. And those tests are pretty uncommon, and we don't know yet what the level is that constitutes a positive level. So let's say you get a test result back and it says you have 5 neutralizing units. Is that good or is that bad? Oh, we don't know that yet. We need large population-based studies for that. That'll be another year or so. So I would not get an antibody test before getting a booster. If you're in that group that I talked about, over the age of 65 or between 50 and 65 with underlying health conditions, just go get it and don't bother getting tested first. And the ACIP and the CDC and the NIH all agree with me. Any other questions? No? All right, we'll see you next week.